Since 2005, over 200 patient deaths have been directly linked to monitor fatigue. The Joint Commission released a Sentinel event alert identifying alarm fatigue as the cause of death in 80 events from 2009 to 2012. And there were even more events that caused serious injury. It's estimated that 24 patients die per year because of this. There was a study done by Karen Hayes that showed that when more than 6 alarms are alerting at the same time, it causes caregiver confusion as to what is going on, which one is going off. And it really causes more harm than good to the patient. Another study was done to examine whether nurses, physicians, and respiratory therapists could even identify or differentiate which alarm signals can be heard on an ICU unit. And out of the 33 alarms that they examined, they could only correctly identify 50% of the critical alarms. And those are the alarms that are more louder than the other alarms, or they have a more detectable rhythm, and only 40% of the non-critical ones. So that's kind of something that needs to be re-examined. So we talked about, the more than 6 alarms, that's a problem. What else is the problem? Well, we have on our units, we have the IV pumps that are beeping constantly. We have patients on bed exit alarms that are going off constantly. We have the SCD machines beeping. We have the ventilators going off. We have feeding pumps, wound vacs. Everything's got alarms. And since 1999, more than 40 different alarms are often used on ICU and telemetry units. It's a lot of noise. So what do we do about it? We need the medical alarms. They're the physiological monitoring standard of care and practice. They enhance our patient safety when they are used correctly. They notify us when our patient's status is deteriorating, and they notify us when the device itself is malfunctioning. Let's talk about their reliability. Most alarms are set for a high sensitivity, but the specifics are low. Meaning, an ideal alarm would be set for, it would never miss a clinical event, but it also would never alarm unless a clinical event occurs. We haven't quite got there with alarms yet. So the thresholds are set for high sensitivity, but their specifics are low. So that's going to cause a lot of false alarms. Research has indicated from numerous studies that up to 99% of alarms do not require nursing interventions. So what is causing this? Contributing factors are nuisance alarms, false alarms, and excessive alarms. Nuisance alarms usually are due to patient movement and improper lead placement. Your patients move, their leads move, they pick up artifacts, their electrodes get moved, or they're not even placed right because your patient tries to put them on back on and they go on the wrong place. Or your tech did not properly put them on in the right place. False alarms, too strict of parameters oftentimes. We have a defaults. Your alarms have automatic defaults depending on how your unit is monitored. Some patients, maybe you need to increase those parameters. I'm talking about a patient with chronic AFib that is going to constantly beep every time that heartbeat goes over 110 beats per minute. Or if you have a natural person that has bradycardia but is stable and their heart rate dips be a little bit below 50 when they're sleeping, that is what I'm talking about. Of course, patients need to be carefully assessed, and this needs to be, discussed with your physician before you, would determine alarm parameters, and you need to know that you have the ability to reset parameters. But this has been documented as evidence-based practice from the Association of Critical Care Nurses and the Joint Commission as a way to decrease false alarms. And alarm malfunction themselves, sometimes, if your alarms are not properly hooked up or anything, they will cause false alarms. Excessive alarms. Just because we have the capability to monitor people does not mean they need to be monitored. The American Heart Association has guidelines as to who should be monitored and for how long. The more people we have monitored, obviously the more alarms are going to go off. So talk with your provider as to if this patient really needs to continue monitoring or not. And if you can get an order to discontinue if there's no really indication as to why he should or she should be monitored. So we can also cut down on the noise with this evidence-based practice guidelines. The Association of Critical Care Nurses and the Joint Commission and also the ERC Institute, they recommend all of these guidelines. Again, we talked about only monitor patients with clinical indication to do so. Guidelines, American Heart Association is the gold standard. Proper skin preparation before EKG electrode placement. We use soap and water to wash the area, not alcohol, because that dries the skin out. If your patient's hairy in the area, we want to clip the skin. Also, we want to change the electrodes daily and as needed. Mm-hmm. I carry a pocket full of electrodes in my pocket for changing electrodes. This, needs to be done. This will decrease decrease false alarms up to 46% by doing these interventions. Customizing the alarm parameters to individual patient or specific population. Again, like modest changes of default parameters would, indicate perhaps, moving the high heart rate up to 130 in a stable patient that is a little tachycardic, or, lowering the bradycardic to 50 instead of 60. Considering a 5 to 15 second delay on SpO2 setting and reducing the threshold to 88 after you assess your patient. Especially sometimes when the patient is like eating or something like that, that can cause a lot of the alarms to go off during that time when the patient is actively doing something. That in particular can set off the alarms too. By doing that, false alarms have been reduced up to 85%. Big thing here, troubleshoot the alarms when they first occur. Don't just ignore them, and definitely do not turn them off. What can managers do to help the nurses? First of all, they'll provide the initial and ongoing education on alarm safety to all the staff. That's very important, and to provide the culture to support the evidence-based practice. inventory all the alarms to make sure they're functionable and they're audible, and the alarms are at the defaults that are required and necessary, especially the ones that are at the high clinical level, like the ventilators and areas that need to be addressed for high clinical risk settings. Make sure everybody understands what the critical alarms are and knows the difference between the critical alarms and non-critical alarms. An interdisciplinary team is very important that that's formed. And they really recommend, it's really recommended that senior leadership be involved in this. It's been demonstrated that better quality outcomes have been associated when hospital boards of directors spend 25% of their time on quality issues and receive a formal quality performance measurement report. But the thing is also that they need to realize it's the system that needs to be changed, not the employees. So, but this team, it needs to include not only those managers, but the nurses, the primary nurses, the respiratory therapists, the technicians, quality control, everybody involved. So everybody has a stake in this to improve, to discuss what defaults should be, when should parameters be changed, what other key issues should be addressed here. So, let's review what nurses can do here. We talked about the proper skin preparation, soap, water, and then roughen the skin a little bit with a washcloth before you put the electrode on. Customizing the parameters for each patient based on their condition. Only monitor patients with clinical indication. And ask your provider, this patient, they really don't have any, the cardiologist has already cleared them for discharge. They're just here, waiting to get, a GI consult now. Do they need monitoring still? Mm-hmm. EKG electrode changes, the SpO2 monitor settings and decrease the threshold. And then encourage the formulation of a task force, or join it if you have one on your unit. Mm-hmm. So the crises alarms, I mentioned them, what are they, and what would cause them to occur. Crises alarms are triggered by your potentially threatening events, something that you would call a code for, obviously. VFib. Actually, crises alarms usually are not missed because those are the ones that are very loud, audibly, but it's the ones before those that are often missed. Nobody wants to admit turning down an alarm or turning one off, but we know it's been done, and it's those alarms that precede the critical alarms that can prevent the critical alarms from happening. So we all need to look at what we're doing to use these interventions to help patients, improve patient safety. In the future, it's predicted that smart alarms will be able to analyze multiple parameters of a patient's condition and separate the physiological changes from artifact to confirm whether a change is real or false, and only notify the nurse when it's real. And better monitors will be able to automatically customize alarm settings and identify the patient deterioration for individual patients automatically. But for now, we need to, make patient safety a priority by just doing what we can with taking steps to prevent the monitor alarm fatigue and what we can for alarm safety. So that's my presentation. These are my references.
Yes.
So
Good
if
job.
I have any questions?
Well, when I recognized you, I did it I was in another patient's room, and one of my patients, it was just her, tube feeding going on. But nobody went, I was in another room for at least 10 minutes. Nobody went into the room. Like, and that always bothered me. I'm like, if I hear, because you never know what that other nurse may be doing. So if you're helping out, because people say, well, that's not my patient. Yes, it is. You may not be assigned to that patient. Because one day you're going to need them, and they're not going to be there for you. So you're always, if you're on the unit, all those patients are your patients.
I agree. It's a communication issue that, it's all the alarms, whether it's an IV beeping. If I walk by a room and somebody's IV's beeping,
If I can't do
I will
it, hey, you need
but yeah, it's all of that noise that causes stress. So, that's something that, you should maybe bring up in a huddle or talk to, charge nurse or something if you think that, you're trying to help the patient and the whole staff.
Very good.